This presentation will explore the study from the Medical Journal of Australia published in 2015, titled The Extra Resource Burden of In-Hospital Falls, a Cost of Falls Study. The purpose of this assignment is to present an overview of the paper, followed by a comment on the relevance to the Northern Queensland Primary Health Network, as well as how well this paper adheres to the STROBE checklist, and therefore its implication on health policy. The background for this study is that in-hospital falls cause a significant level of harm in acute care hospitals through increasing hospital costs due to their impact on hospital length of stay and use of resources. Previous studies have had a poor capture of falls events or from a single source that makes the costings presented inaccurate. Additionally, these studies target falls with serious injuries and may underestimate the total burden of falls. The relevance to Queensland is that a 2012 study from the Queensland Health demonstrated that there were 2,200 falls resulting in injury amongst patients, which presented a rate of 0.79 in-hospital falls per 1,000 patient days in those aged 65 and over. Of the 80% of falls that result in injury, 16% of these caused fractures. The aim of the study is to describe the difference between hospital length of stay and costs of patients who experience at least one in-hospital fall and those that don't. Secondary aims were to calculate the difference between hospital length of stay and costs with those that had an injurious in-hospital fall to those that had a fall without injury. Additionally, it aimed to estimate the incremental change in hospital length of stay and costs associated with each in-hospital fall and injury. This is a multi-site prospective study of the costs of falls, and it's part of the Six-Pack Falls Prevention Cluster randomised controlled trial, which, as described in a previously published protocol, involves the collection of data on 150,000 patients over a 15-month period to describe their characteristics, outcomes, and hospitalisation cost data. The study population is all patients admitted to 12 acute hospital wards in 6 public hospitals, which is the control arm of this Six-Pack trial, which included 4 general medical, 2 general surgical, 1 gen med short stay, 4 specialist medical, and 1 specialist surgical ward. Data was collected over a 15-month period and gathered via daily patient medical record audit, verbal reports from the ward nursing unit manager, and triangulation with falls recorded in the hospital incident reporting and administrative database. A falls event was described as any event resulting in a person coming to rest inadvertently on the ground or other lower level. Physical harm was classified into 4 groups, the first being no injury, so no physical damage, the second mild injury with including a bruise, swelling, abrasion that doesn't need medical treatment other than simple analgesia, moderate injury, which included dislocation, sprain, or anything requiring medical or surgical treatment, and a major injury, which included fracture or head trauma. Patient hospital utilisation was described using inpatient length of stay, which was the total number of bed days, and hospital episode costs from clinical costing data. Statistical analysis was undertaken using means and medians for hospital length of stay and costs, as well as using multivariate regression models to analyse length of stay and costs, adjusting for age, sex, cognitive impairment, and hospital location. Finally, sensitivity analysis was undertaken through removing those that were extreme statistical outliers or might have other influences. There was a total of 27,026 patient admissions included in the study, and of those 3.6% had one fall and 1.3% had a fall injury whilst in hospital. The total hospital cost of these inpatient falls was 9.8 million Australian dollars. 6.4 million of that was attributed to non-injured fallers and 3.4 million to injured fallers. The adjusted length of stay for fallers was 8 days longer than for those that did not have a fall whilst in hospital, and that presented an extra $6,669 in hospital costs, with a p-value of less than 0.001. Each additional fall was associated with a longer length of stay and additional hospital costs. And 3 or more falls in admission had 23 days longer hospital length of stay than those that did not have a fall, and an extra 21,000 Australian dollars in hospital costs. Within the cohort of fallers, the mean length of stay for an injured faller was 4 days longer than for non-injured fallers, with a p-value of 0.001. However, cost was not significant. There was no statistical difference in hospital length of stay or costs for the severity of the fall-related injury. And compared to non-fallers, those who did not sustain the injury had a length of stay increase of 7 days and an increase in costs of over $5,000. Of the sensitivity analysis that was performed, there was no change in results. The strength of this study is that it confirms that the increase in resource burden associated with an in-hospital fall occurs regardless of the injury sustained. Additionally, it was a multi-site prospective study, and it included this sensitivity analysis that I alluded to earlier. Finally, its benefits were that it reported confidence intervals and significance for multiple dimensions of hospital length of stay and cost analysis, comparing between in-hospital fallers and non-fallers and those that had injuries or didn't have an injury. Some of the weakness and limitations included that there was unmeasured confounders that may have influenced hospital costs and length of stay, as well as limitations on data collection and how the conditions were coded. Applying this to the Strobe checklist, so the background and objectives adequately identified the issue for the community as well as the main objectives for the study. However, no hypothesis was applied. In regards to the study design and setting, they identified the key elements and where the hospital was going to be carried out. The participant arm of both the methods and results was unable to clarify whether there was incomplete data or loss of follow-up, which is one of the detractors from the study. In regards to bias, this was not discussed in the study, particularly measurement bias, as this was part of a much larger trial, the six-pack trial. There should have been considerations for how this larger trial might have applied to the measurement bias of in-hospital falls. Additionally, the study size was not discussed in the methods. Both the quantitative and statistical variables were described appropriately. In terms of the data and results, the descriptive data and outcome data identified appropriate characteristics of study participants and outcome events, as well as identifying that the costing data was missing for some certain hospitals. And all the results, both unadjusted and adjusted estimates, were provided. Looking at the discussion now, the key results were identified, as well as some of the major limitations of the study. The results seem not to inflate their conclusions, and it referred to other studies in the discussion. Whilst this study is generalisable to both surgical and medical wards, they were unable to generalise this study to the community as a whole, as the population was an unwell hospital population. And finally, the funding was acknowledged appropriately, which described that this had NRHMC funding, as well as from the Victorian Department of Health. The significance of this study for public health is in hospital falls prevention strategies. It described that in-hospital falls are very prevalent within the hospital system, and they're costly. And they cause changes in care pathways, discharge planning, and patient confidence to not just those that have injuries, but also those that have non-injurious falls. Strategies needed to be put in place include reducing the incidence of falls and their impact. These include things like vision changes by providing adequate lighting or treatment in cataracts, identifying those with mobility problems and at falls risks, adjusting people's medications appropriately to reduce their antipsychotics and benzos, as well as supervising them when they mobilise to the bathroom. And this study provides an impetus to invest in interventions because of the significant cost. Overall, this study was a good study demonstrating the costs and impact of falls, both injurious and non-injurious. And I'd just like to acknowledge the use of these photos, which is from my workplace in Sydney.